We're so lucky to be joined by Dr. Paul Offit tonight. I don't think Paul needs much introduction to this crowd. We're lucky to have him on our board of trustees. As you all know, he is an internationally recognized pediatrician, co-developer of the rotavirus vaccine, and today he's been busy as a member of the FDA's Vaccine Advisory Committee. Paul, it's been a busy day for you, we know, through an all-day meeting with the FDA, followed by, it sounds like, an interview with every TV news station and newspaper in the country. So we're always grateful to have you here with us to answer the questions that we know are at the top of everyone's minds, not just here, but in all of our households and around the country. So thank you again for making time for us today.
Happy to do it.
So Paul, I want to start with the headlines of the day. Today, you were part of an advisory committee for the Food and Drug Administration that was reviewing the potential for using the Pfizer-BioNTech COVID-19 vaccine for kids age 5 to 11. So help us understand the decision that you were making today with the committee.
Right, so we were asked to vote on the following proposition, that we agree that the Pfizer-BioNTech vaccine, given as a 10 microgram dose, which is a third of the vaccine, the dose given to those 12 and over, given as 2 separate doses, 3 weeks apart, that the benefits of that dosing schedule outweigh the risks in children between 5 and 11 years of age. That was the question. So what we had was a basically 2,400 child study where 1,600 children got the vaccine and 800 children got placebo. There were 19 cases of COVID in that study, 16 in the placebo group, which meant the vaccine was about 91% effective. So it's always hard when you're on this committee and you're being asked to make a recommendation for millions of children based on a study in just a few thousand children. I mean, how predictive is that study? So I think for me anyway, and I think for the other voting members, the issue is never when do you know everything? You never know everything. The question is, when do you think you know enough to move forward? So what do you know? What do you know about the 5 to 11-year-old? You know that 1.9 million children between 5 and 11 have suffered COVID. You know that 8,300 have been hospitalized with COVID between 5 and 11. You know that 1/3 of those who have been hospitalized were in the intensive care unit. You know that about 2,000 children in that age group have suffered something called multi-system inflammatory disease, which can be quite severe and fatal occasionally. And you know that 143 children in that age group have died of this virus. You know that. And you know you have a vaccine that works, at least in this 2,400 child study. But you also know that the vaccine works well in the 12 to 15-year-old age group and the 16 and above group. So it's a big platform there of older people who've gotten this vaccine. But the big but for this committee meeting, and what took us so long to eventually get to a vote, is the issue of myocarditis, which is inflammation of the heart muscle. Now, if that happens to someone who's 45, that has a different emotional resonance than if it happens to somebody who's 5. So what did we know? What did we know about myocarditis? We know that for the 16 to 29-year-old, the risk of that disorder is about 1 in 20,000. Now, the good news, if there's ever good news about myocarditis, is it's short-lived. It tends to be self-resolving. It's transient. It's not like the typical viral myocarditis where the virus affects your heart muscle, like viruses like Coxsackie, where often those children are not only in the hospital, they're in the intensive care unit, and about 10% get heart transplants. That's a different beast. Unfortunately, it's given the same name, myocarditis. So I think that's what people think of. But so you know that at least for the 12 to 15-year-old, so that's it. So 1 in 20,000 for the greater than 16-year-old. For the 16 to 17-year-old, it's 1 in 5,000. That's not so small. So now you're worried. For the 12 to 15-year-old, was it going to be greater or lesser than the 16 to 17-year-old? In other words, is it getting bigger and bigger as you get younger and younger? Well, the answer is no for the 12 to 15-year-old. Both in Israel and the United States, the incidence of myocarditis was actually lower in the 12 to 15-year-old than it was in the say 16 and 17-year-old. So that was reassuring. So now you're thinking, for that 5 to 11, hopefully it will be lower still. The other thing that's good news is at least classic myocarditis is generally a post-pubertal phenomenon. So that also makes you feel better. And remember, myocarditis is also a consequence of the disease. About 1 of every 45 people who get COVID have myocarditis. With MIS-C, that multi-system inflammatory disease, it's more like 50% of those kids get that. So there are never risk-free choices. There's just choices to take different risks. And it was our feeling in the committee that the greater risk was the risk not to get a vaccine.
So I think, one of the really interesting parts of the process that we've all been through, is seeing this, this decision-making process at work, live stream on the internet, right? It's all of your discussions are out there. One of the questions that we got beforehand as we try and understand this process is a question about the fact that about the numbers of kids who are involved in the study. And if I recall correctly, over the summer, the FDA had actually asked the vaccine manufacturers to expand the number of kids who were in the study. Was that specifically to get a broader pool to look for the risk of myocarditis?
No, I mean, when you're looking at a risk of something like one, even something as common as 1 in 5,000, you'd really need to do a much bigger study to figure that out. But the general risk, I think, is closer to 1 in 20,000 overall. So no, I think the reason was because they wanted more numbers for efficacy. So
yeah.
They had wanted at least 21 cases of efficacy. It didn't work out that way. It ended up being 19, but close enough. It's the thing about this is it's always been an emotional issue for me. And that's I wrote a book called You Bet Your Life, which came out about a week ago. But and the reason I wrote it was the story I'm about to tell you. When we approved the vaccine for the 12 to 15-year-old, that was a 2,300 child study. Half got the vaccine, half got placebo. So it was 1-to-1 study. There were 18 cases of COVID in that study, all in the placebo group. So 18 children suffered COVID, all in placebo. I'm sure that the parents who were in that study would have all preferred they'd gotten the vaccine, but they went with the flip of the coin. I got a lot of pretty pointed emails after we recommended that, basically saying 2,300 children, that's all you want to do? I mean, you just did 40,000, Pfizer just did 40,000 adults, and now you're going to do 2,300 children and then recommend it for millions of children? To which my response is, we could do 23,000 children. We could. And aside from the time that it takes, now you're not going to have 18 cases of COVID. You're going to have 180 cases of COVID, most if not all in the placebo group. I mean, what price knowledge? What human price do you want to pay for knowledge? And the reason that is emotional for me is the following story. I am a child of the 50s. As you can tell from your screen, since this is video, I'm an older person. Okay, so I was a first and second grader in the 1950s. When Jonas Salk made his polio vaccine, he made it by taking the virus, growing it up in cell culture, purifying it, and killing it with a chemical, formaldehyde. He then tested that vaccine, that whole-killed poliovirus vaccine, in 700 children in the Pittsburgh area. It induced an excellent immune response, and it appeared safe. He went to his wife that night, Don, and said, got it, eureka, this is it. Then they proceeded to do a study that he didn't want to do. It broke his heart. He couldn't imagine doing this kind of study where you give placebo vaccine to children, first and second graders in the 1950s in the summer. He couldn't imagine that. Nonetheless, that's what happened. 420,000 children got his vaccine. 200,000 got placebo. 1.2 million children served as observed uninoculated controls, actually out of respect to him, because he didn't want to give a shot of salt water. So when it was all over, it took about a year to do that study. It was probably the biggest study of a medical product ever. But after it was done, the person who ran that study stood at the podium at Rackham Hall in the University of Michigan and said those three famous words: safe, potent, effective. And that headline was on every newspaper in this country. And church bells rang out, and synagogues held special prayer meetings, and the Voice of America announced it over to Europe, and department stores stopped while that announcement was made. Well, how did he know it was effective? He knew it was effective because 16 children died of polio in that study, all in the placebo group. He knew it was effective because 36 children were paralyzed in that study, 34 in the placebo group. But for the flip of a coin, those first and second graders could have lived a long and fulfilling life. I was a first and second grader in the 1950s, so I know exactly how old they would have been. And the question we always have to ask is, when do you think you know enough? And there's a price to be paid for knowledge, and I think we don't quite understand what that is. I think when I see children coming into our hospital who are volunteering for trials now down to 6 months of age, God bless them. I think it's a brave thing that they do.
That's such a powerful story because it really helps communicate how, that when we're looking at that risk benefit ratio, yes, you're looking at the risk to any one individual, but you're also looking at the risk and benefit to the entire population. And as you say, those numbers, they start to add up when you wait and wait and see. And so that's, it's I think a lot of people, really respect the decisions that you have to make in the face of such uncertainty. But we're also seeing how then that risk benefit ratio then filters down to the individual level. So, for a parent of a 6-year-old, say, how do you assess the risk of, a potential side effect of the immunization or a potential side effect of COVID-19?
Yeah,
What
and so
advice would you give them?
I think you go through the kind of numbers that I just went through. I mean, generally we're terrible at assigning risk, at determining relative risks. I mean, when people ask me what's the most dangerous aspect of vaccination, it's driving to the office to get them. I mean, if you just look at where your biggest risks are, it's getting in the car to go there. But people, if you tell them that the risk is 1 in 5,000 or 1 in 50,000 or 1 in 2.4 million, that's not what they hear. What they hear is, that you're saying it's possible. The New York State lottery, for example, a few years ago, to buy a lottery ticket to basically win a 14 million to 1 chance, just sold it with a simple phrase, "It can happen to you." And I think they get it. And I think that's the story with this. I don't think people understand relative risk. So you can go through the numbers that I just went through, and to tell people to realize that you have a 1 in 45 chance of getting myocarditis if you get infected. You have at most a 1 in 5,000 chance of getting it, 100-fold greater chance of getting it if you got the vaccine. And for these other age groups, it's much, much greater than that. So, but people don't hear that. And sort of the sin of omission versus the sin of commission. If I give something to myself or my child and I'm hurt by it, that's viewed as differently than if I do nothing and then something happens to me. But doing nothing is doing something. I mean, doing nothing is taking just a different risk. And you need to sort of determine that in a dispassionate way, which none of us are capable of doing.
I think that's such an important psychological point for everybody, as when we think about the decisions that we're making for our children, what does it mean to be a good parent, right? And there are ways in which sometimes being a good parent means doing something, and then there are sometimes that being a good parent feels like not doing the thing. And it's shifting that mindset based on all of these conditions that we're dealing with that are so uncertain. So as we look ahead, what's the path forward? What happens next now that your committee has approved this use?
Well, I think probably the question people are most interested in is, when do we get to the end of this, right? I mean, what happens next in terms of just immediately with the 5 to 11-year-old recommendation? What I suspect will happen is that the uptake will be poor. If you look actually at the percentage of people vaccinated, say over 65, between 50 and 65, between 40 and 50, as you go down, a smaller and smaller percentages are vaccinated as you go down in age. So what percentage of 12 to 15-year-olds have been vaccinated? This is a vaccine that's been out for a few months, about 45%. So I suspect it'll be lower than that, which is too bad, because I think the vaccine is a value. I think we need to get to about at least 90% population immunity from either natural infection or vaccination. Now, there was just a study that came out today in the Journal of the American Medical Association, and what they did was they looked at like 1.5 million blood donations to answer the question, what percentage of those blood donations contained antibodies, either from natural infection or vaccination? And the answer was 80%. So we're probably at about 80% population immunity, because I'm arguing that either vaccination or natural infection protects you against serious illness. But given the contagiousness of this virus and given the efficacy of the vaccine, I think we're going to need to vaccinate probably another 30 to 40 million more people, even though about 65 million aren't vaccinated. If we get to another 30 to 40 million, get us into the low 90% range, and I think we can significantly slow the spread of this virus. But we have a resistant population.
You mentioned a ton of ideas that I want to come back to. later as we dig into this over the course of our discussion here. I'll note that I'm actually quite interested in reading that paper about, with the blood donors, because I was one of them. So it's always exciting to see, outcomes of participation.
It's in this one.
All right, it's on my reading list. Okay, so let's kind of tackle some of the ideas you brought up one at a time. So let's think, and it's interesting that you note this trend in the age groups and uptake of vaccine, because even actually within my kid's school district, we see that just from 18-year-olds to 12-year-olds. But as now that this decision has been made, the CDC meets next. Can you help us understand the different roles of the FDA committee and the CDC committees?
Right. Well, so I'm on the FDA's Vaccine Advisory Committee. We give advice. So we just gave our advice to the FDA. They will either choose to follow or not to follow that advice. I suspect they're going to choose to follow it within the next day or two. Then what happens is on November 2nd and 3rd, it goes to an advisory committee for immunization practices, which advises the CDC. So the FDA is a regulatory body. What the FDA basically says is the company, Pfizer, can now distribute that vaccine to the public for the 5 to 11-year-old age group. But everybody's going to wait to see what the CDC says, because the CDC sometimes will sort of layer it. They'll say, this particular group within the 5 to 11-year-old age group is recommended to get it. The other group should be considered to get it. But I think if I have to make a prediction, and I'd like to point out that I picked the Eagles to beat Las Vegas, but if I had to make a prediction about what's going to happen on November 2nd and 3rd, I think it's the 3rd is when they're going to make this decision. I don't think they're going to restrict. They're going to have a layered thing, because a healthy 5 to 11-year-old who has no comorbidities that put them at high risk of serious disease can suffer and be hospitalized and die from this virus. So I don't see them making a distinction. I think they're just going to say all 5 to 11-year-olds, but we'll see. But so they're the recommending body. The FDA is the regulatory body. And
then what's the outlook for kids even younger than 5?
Right. So there are studies being done between 6 and 5 years of age. Interestingly, Moderna has also submitted, and they're asking for the 6 to 11-year-old. I'm not sure why they didn't do 5. I really don't think there's any necessarily good reason for that, but that's Moderna. So there are also studies being done for the 6-month to 5-year-old that presumably would be, could be submitted to our committee before the end of the year. I know that they've asked us, the committee, to reserve dates in December. So whether it's going to be December or not, we'll see. And that's a much lower dose. So the adult dose for Pfizer is 30 micrograms. The 5 to 11-year-old dose is 10 micrograms. The 6-month-old to 5-year-old dose is 3 micrograms. So it's sort of, full dose, third of a dose, 10th of a dose.
And then that's based on his physiology, differences in immune systems. So doing some of that testing to make sure what's the safest dose that can still be effective.
Right. Remembering that children are not little adults, with the exception of my daughter, who was 30 when she was 4, but yeah.
Okay, so let's broaden our discussion away from just children and talk about some of the questions that have came through about vaccines in general. So one aspect of the uncertainty around the vaccines right now is, how effective is it against the Delta variant? And what are the goalposts for vaccines?
That's a great question. I think that's the question of the day. What is the goal of the vaccine? I would argue the goal of a vaccine, the goal of any vaccine, is to prevent serious illness, meaning the kind of illness that caused you to seek medical attention or go to the hospital or go to the ICU or die. That's the goal of a vaccine. That's a reasonable goal for a vaccine. This goal accomplishes that. These vaccines accomplish that goal. Whether it's the Moderna vaccine, the Pfizer vaccine, or the J&J vaccine, all of those vaccines have held up to still have excellent protection against serious illness through the Delta variant for all age groups. So you could argue we won, good enough. But we have held this vaccine up to a standard that we hold no other vaccine up to, which is we also wanted to protect against asymptomatic or mildly symptomatic infection. The protection against serious illness is mediated by immunological memory cells, memory B cells, which tend to be long-lived and induced very well after these vaccines for years. I think likely you'll be protected for years against serious illness. But protection against mild disease or asymptomatic disease is mediated really primarily by neutralizing antibodies in your circulation at the time when you're exposed, in your bloodstream at the time when you're exposed. And those fade over time. It's true for every vaccine. After every vaccine, the level of neutralizing antibodies in your bloodstream will start to decline. So if that's the goal, to try and keep those neutralizing antibodies up, then we're talking about probably fairly frequent booster doses. And I just don't frankly agree with that as a strategy. And this is why the booster dose story has been such a mess. It's probably a question people may have. So let me just give you one rant on booster dosing.
Go for it.
If the goal is protection against serious illness, there are clear data that if you're over 70, and you have gotten a booster dose as compared to just the standard, say, 2 doses for an mRNA vaccine, you benefit from a booster dose in terms of protection against serious illness. And that's it. There is no other group that has clearly been shown to benefit from a booster dose in terms of protection against serious illness. None. I can promise you that the people who are in the intensive care unit at the hospital at the University of Pennsylvania are not there because they haven't gotten a 3rd dose. They're there because they haven't gotten any doses. And that's really at the heart. If we want to get on top of this pandemic, that's the group to make sure it gets vaccinated. But nonetheless, I think what happened was when President Biden stood up at the podium on August 18th and said, booster doses will be available for everyone over 16 years of age by September 20th. He opened a door that has just not closed, and it's just gotten, frankly, wider and wider. I can tell you at our committee, we tried to limit it to older people, but that just got wider and wider as it went to the CDC. And now, frankly, if you look at all the people who are recommended to receive a booster dose, it adds up to about 85% of the population. The minute that they had added obesity and depression, you moved into about 85% of the population. Roughly a third of adults fall into the category of obese. So I just don't think we're doing a lot of good. I think we would have done far better to take those doses and just send them overseas, where we would have done more good, not only there, but even for here. In terms of the variants, the Delta is the first variant where the target is a little off to the side. I think you don't quite hit the Delta variant with these vaccines as well as you did with the first 2 variants. But still well enough to protect you against serious illness. It's actually remarkable, actually, how well these vaccines work. Nonetheless, we continue to damn them. We do. We've damned them in 3 ways, 3 subtle ways. I think the CDC has not communicated this particularly well. The first was when there was an outbreak in Provincetown, Massachusetts, where thousands of men came together to celebrate July 4th. 79% of them were vaccinated. Nonetheless, there was an outbreak. 346 of those men got COVID, most asymptomatic or mildly symptomatic, but 4 of them were hospitalized for a hospitalization rate of 1.2%. So got a vaccine, got sick, was hospitalized, 1.2%. That's good. That's a win. That's as good as you're going to do in the world of vaccines. But thus was born the term breakthrough illness. The CDC actually used the term breakthrough to describe a mild or asymptomatic infection. That's not a breakthrough. A breakthrough implies failure. That's a win. When Brett Kavanaugh, who is fully vaccinated, gets an asymptomatic infection, if you watched it on television, you would have thought he was in the ICU. I mean, the way they keep using the word breakthrough. And Lindsey Graham got this right. It's not often that you get to quote Republicans when it comes to science or medicine. I know Larry tells me he hates it when I do this, but I'm doing it anyway. But in any case, what Lindsey Graham got this right. When he, despite being fully vaccinated, got an upper respiratory tract infection with sinusitis, he said, and I quote, "This would have been much worse if I hadn't been vaccinated." Right. Lindsey Graham got it right. So I think that was mistake 1. The use of the term breakthrough. Mistake 2 was, and it came out of the same outbreak, when the CDC said that if you're vaccinated and you have an asymptomatic infection, you are just as likely to be contagious if you're not vaccinated and have a mildly symptomatic infection. That's not true. Studies have shown that wasn't true. You're much better off having been vaccinated. You will shed less virus for less a period of time. You are less contagious. So that was wrong. And then the third thing was when President Biden got up to the podium and said, booster doses for all. What he just said to everybody was 2 doses wasn't enough. And that's not true. So we just take this remarkable vaccine and continue to damn it.
So just to dig into a couple of things that you mentioned. So one question is about thinking of this vaccine. Is it actually a 3-dose vaccine, or is it a two-dose vaccine with boosters that we may have to get future boosters at some intervals moving forward into the future?
Great question. So if you ask Dr. Fauci, what is this a 3-dose vaccine? He will say yes. If this was not a pandemic, this would have always been a 3-dose vaccine. And he based on, I know this, but I've had long talks with Dr. Fauci on the phone about this. He bases this on the fact that if you look like the hepatitis B vaccine or the polio vaccine, the only way you get decent immunological memory that will protect you against severe disease if you have at least a 4 to 6 month interval between doses. And that's true. That is true for those vaccines, those inactivated viral vaccines like Hep A or polio. But is it true of these vaccines? I mean, the mRNA vaccines or the vector virus vaccines aren't inactivated vaccines. They're different. They're genetic vaccines. So we're learning about them. And so far, all the evidence is that you induce great memory for even with 2 doses given close together. So there's no evidence that that memory has faded, none. So that would make it a 3-dose vaccine. And that's where Dr. Fauci thinks we are. He thinks this 3rd dose is the end of it. On the other hand, they give this mixed message, the CDC and the administration give this mixed message that, neutralizing antibodies are fading. People can still be contagious. It may mean they miss time from work, especially in a hospital or a long-term care facility. So we need to keep those neutralizing antibodies up. Now you're not talking about a 3-dose vaccine anymore. You're talking about a booster dose. With the J&J vaccine, however, I would argue that is a 2-dose vaccine. It's always been a 2-dose vaccine. It should have launched as a 2-dose vaccine. J&J were in the midst of doing a 2-dose trial when at the end of February, we approved that as a single dose, knowing it was going to end up being a 2-dose vaccine. So that's not, that second J&J dose is not a booster dose. That is just part of the 2-dose platform.
Okay, so I should go get my 2nd dose. But to your point that, it so far from the evidence that we have, this isn't something like the flu shot, for instance, that, we're going to end up having to get every single year.
Right. No, flu's different. Flu mutates so much from one year to the next. The natural infection or immunization the previous year doesn't protect you against serious illness. You could still be hospitalized or die because the virus has mutated that much. Flu is a moving target. This is not that. Coronavirus actually are fairly slow mutators. We've had basically 3 variants within a period of a year and a half, and frankly, all of them are still well neutralized, well protected by the vaccines that were developed against a virus that came before the first variant. It was really the virus that raised its head in Wuhan that was sequenced and published in January of last year. That's before the first variant, and yet still the vaccines work well. So this is not flu.
Okay, the next question that lots of people have asked is about the recommendations for mixing and matching different vaccines. Can you help people make sense of what the guidance is there?
Right. I think that's largely a matter of convenience. I think that's what it is. So if you've gotten a J&J vaccine, you could get a J&J as your 2nd dose, or you could get a single dose of mRNA vaccine as your 2nd dose. If you've because if you're going to a place that doesn't happen to have one or the other, then you could get either one. If you've gotten 2 doses of Pfizer and you now want to get your 3rd dose, you could get either Pfizer or Moderna's or J&J's, frankly. I mean, so they basically allowed this. There's not really much in the way of studies on this. Probably the best studies are if you've gotten a J&J vaccine. When you look at if you get an mRNA as your 2nd dose, you actually get a better neutralizing antibody response than if you get a J&J as your 2nd dose. But remember that the 2-dose J&J vaccine is 94% effective against symptomatic illness. So they're all good choices, basically.
Okay, and can you also explain the differences between the different dosage amounts between the Pfizer and the Moderna boosters? Why does Moderna have a lower dose for the 3rd shot?
Right. So Moderna, you get 100 micrograms, 100 micrograms. The 3rd dose is 50 micrograms, largely due to side effects. The 100 microgram as a 3rd. Remember, the side effects are often based on your immune response. So the more vigorous your immune response, the more vigorous your side effects, like fatigue, headache, muscle pain, joint pain, et cetera. So that's the reason, side effect.
Great. Okay, and then now I want to switch gears a little bit. You mentioned this earlier, is, thinking about the long-lasting immunity that comes from vaccines versus the immunity that comes from getting an infection. How do those two intersect? To what degree, do we just put our stock in immunity after naturally occurring infection? What's the benefit of getting a vaccine after you've had natural infection? What do we know about that interaction?
I think all the evidence to date is that if you've had a natural infection, even if it's an asymptomatic infection, apparently that is enough to induce immunological memory to protect you against severe illness down the road. So you could argue, I've been naturally infected, I don't need to be immunized. Now, there are studies done recently in Kentucky, where if you take someone who's been naturally infected, or take people who are naturally infected and divide them in half, and give one group an mRNA vaccine and don't give anything to the other group, over that next few month period, you decrease your incidence of infection by about 2.5-fold by getting that booster. But by infection, I mean either asymptomatic infection or mildly symptomatic infection. I'm not talking about severe disease. So I think if somebody comes to me and says, I've been naturally infected, I think I'm protected against serious illness, I realize that over time I may get an asymptomatic or mildly symptomatic infection, but I can live with that. I think that's fair, actually. And that sort of comes up in the mandates. I can tell you the administration is thinking about this. If people say, look, I've been infected, in Europe, or in Canada, I get a passport. I get my vaccine passport by just being naturally infected. Why not here?
And that's just based on an antibody test that provides evidence that you have those antibodies.
And epidemiological evidence. I mean, there was just a paper by Michael Nuzenswag's lab that came out in Nature, looking basically 1 year post natural infection, and protection against serious illness is excellent.
So before we move on to some other topics, one more specific question about the kids' vaccines. So if a child gets the lower dose vaccine now, do they go back for an adult dose when they turn 12?
That's a good question. I don't know.
Do we know?
One doesn't know. So I think if you're if you're 11 currently, you're asked to get a 10 microgram dose. If you're 12, you're asked to get a 30 microgram dose. Now, the data that were presented today, this was a question I asked, actually. Bill Gruber from Pfizer is the one who did the presentation. I asked, do you have a substratification of the 5 to 11-year-old, like the 5 to 6-year-old compared to the 7 to 8-year-old, compared to the 9 to 10-year-old, the 11-year-old? Do they all have the same immune response, the same neutralizing antibody response? And the answer is yes. They all had really pretty much the same neutralizing antibody response. What was a little worrisome is the 3 cases of disease that were in the vaccine group were all older children. They were the 10 and 11-year-old children. And so that makes you worried that maybe that 10 micrograms wasn't enough. But if you look at the placebo group, most of those were 10 to 11-year-olds. So the older kids were getting infected, maybe because they were just more active and out more and participating in sports or whatever. But so that was that when you looked at those data, it made you feel better that if you're 11 years old, get what you can, because I think you benefit from the vaccine.
Well, that's useful as a parent of 11-year-olds. All of us are kind of on the fence about what this means for our kids. Okay, so let's start thinking about what lies ahead. What's kind of in the pipeline in terms of the research that's ongoing. So let's stick with vaccines first. Are there additional vaccines that are in the pipeline, and are we likely to see more of them, or are we likely to see the current vaccines being modified? What's the strategy there, not just here in the US, but really around the world?
Right. So there's the so-called RTSS vaccine for malaria, which is now rolling out. And that's made by taking the hepatitis B surface antigen, basically the hepatitis B vaccine, and then linking it to a protein that's on the surface of the malaria parasite. So that's being rolled out in Africa now. I think we're close to a respiratory syncytial virus vaccine, which will help because young infants, especially, about 5,000 die a year from that virus. It's a respiratory virus that causes pneumonia. I think probably the most exciting thing is the mRNA technology. This is the first pathogen that's been tried on. It's been remarkably successful. And so now people, although the technology it's the first time we've used it in vaccines on a mass scale, research in mRNA vaccines have been going on for 15, 20 years. So we'll see whether or not It also applies to, say, possibly a universal flu vaccine, meaning one you didn't have to give every year, or a better malaria vaccine, or a human immunodeficiency virus vaccine, or a better tuberculosis vaccine. All those studies are ongoing. I think the most interesting thing for me is the fact that you now have clear evidence that the mRNA technology is safe in pregnant women, which I think opens the door for a number of vaccines that can be given in pregnancy. I mean, right now, the whooping cough vaccine is given in pregnancy, pertussis vaccine, and the flu vaccine. But, pregnant women and their soon-to-be offspring also benefit from a respiratory syncytial virus vaccine, a Group B strep vaccine, even a meningococcal vaccine. So I think now that you have that platform, I think you're going to start to see those studies too.
And in addition to that, there are still more COVID vaccines in the pipeline as well. What are the use cases for those, given that we have, a number of vaccines that are already being distributed around the world?
Right, so Sinopharm in China has a whole inactivated viral vaccine like the polio vaccine. Novavax has a purified protein vaccine that's adjuvanted, sort of similar to the hepatitis B vaccine or the HPV vaccine. I think the advantage of other vaccines is that we're not done with this virus. I mean, we're going to be at risk for this virus as long as it exists in the world. We're going to need to have a highly protected population as long as it circulates in the world. And if you don't believe that, realize that we give a polio vaccine to children every year in this country when we haven't had a case of polio in this country since the 1970s. The reason we do it is because polio still exists in Afghanistan and Pakistan. It's interesting that, we don't fear polio, right? Because we don't think about polio anymore. Once Afghanistan immigrants started coming into this country, I know because we're seeing a number in our hospital, suddenly polio was back on our minds because polio is endemic in Afghanistan. And only one of every 200 people who are infected with polio are paralyzed by it. So like SARS-CoV-2, it's mostly asymptomatic spread. And so again, it's that fear that you could feel it actually in the residents, the fear again of polio. It was interesting.
Yeah. No, it really goes to show how interconnected the world is. And when suddenly those connections seem very close to home, it changes our mindset about these diseases. So in addition to vaccines, looking at treatments, looking at antivirals. So what other toolkits do we have in terms of treating diseases like COVID? So we've looked at, we've heard about some of the monoclonal antibody treatments. There are some potential antivirals. What's on the horizon there?
So the way this virus works is it attaches and enters your nose and throat and begins to reproduce itself. Then it makes hundreds of particles, then thousands of particles, then tens of thousands of viral particles. So the replication of the virus goes up and up and up. While that's happening, your immune system kicks in. And when your immune system kicks in, that's when the viral replication decreases. So there's an inverse relationship. Your symptoms are based on your immune response. It's the viral replication alone doesn't cause symptoms. It's the immune response to the virus that causes symptoms. So by the time you're sick enough to go to the hospital, the most important part of the disease process is your immune response, not viral replication. And that's why the keys to therapy are things like dexamethasone, a steroid, which decreases your immune response. And much, much less so antivirals and monoclonals, which frankly don't work at that point. And that's why they're really not used in the hospital. If you're going to use especially a monoclonal, which I think are horribly underutilized, actually. I mean, there are certain groups who, if they are at high risk of serious illness, meaning an older person or people who have various comorbidities, obesity probably being the big one, if you're early in your infection, you have early symptoms of your infection, you really benefit from monoclonal antibodies. But I think there's generally a lack of infrastructure to give them. I think there's a lack of knowledge among physicians about how important they are, but you could save a lot of lives with early treatment of antivirals. With regard to the monoclonal antibodies, it's been a long day, by the way, a really long day. I actually interrupted Wolf Blitzer tonight in one of his questions. It's been that long of a day. But regarding antivirals, they too really need to be given early. So this new Merck product, this molnupiravir, again, everybody's really excited because it's about 50% effective at preventing hospitalizations. Vaccines are like 100% effective at preventing hospitalizations. That's really the way to go. But it's amazing. It's amazing how dug in people are about not giving vaccines. To me, the poster boy for not giving vaccines is Kyrie Irving. I mean, the man is willing to give up at least $17 million to not get vaccinated. I mean, he's not being asked to get a heart transplant. He's being asked to get two shots. It is remarkable to me.
Well, that's a good segue to talking about the issue of vaccine confidence and some of the issues that we're seeing being discussed, especially as there are more employer mandates that are giving rise to kind of these stories. And as we think about how do we talk about this to share the accurate facts of science and build people's confidence, what do you perceive as the potential risks or benefits of looking at a case like a celebrity case like Kyrie Irving? Does that kind of overemphasize some of the potential resistance, or does that kind of put that risk benefit ratio into a level of absurdity that maybe like gives people a wake up call?
No, I think it's fair to be skeptical about anything you put into your body, including vaccines. I mean, when Kaiser Family Foundation did surveys last September, before there was a vaccine, they asked the question, would you get a COVID-19 vaccine? And only about a third of Americans said that they would. Frankly, if you'd asked me that question, I would have said, no, not till I see the data. I think everybody sits around the FDA's Vaccine Advisory Committee table is skeptical about vaccines. So we want to see the data. But then when they did that same survey a few months after the vaccine was out, so now you was in hundreds of thousands, then millions of people, and you saw what the data were in terms of safety and efficacy, then that 30%, 35% became 70% roughly. So that's the skeptic. That's the vaccine skeptic. Fair enough. They are convinced by data. But then there's the other group, who I would call the vaccine cynic. They just don't believe you. They don't believe the medical community. They don't believe the pharmaceutical industry. They don't believe the government. They're more conspiracy theorists. And so, as Neil deGrasse Tyson says, if someone doesn't use reason or logic to reach a certain conclusion, reason and logic are not going to talk them out of it. So what do you do? I mean, I feel sorry actually for President Biden, because I think he's done everything he can do really to figure out how to mass produce. Actually, the last administration should get a lot of credit, Trump administration, for making that vaccine in 11 months. That was remarkable. But Donald Trump never called it the Trump vaccine, and I've given this a lot of thought. I think the reason he didn't do that is deep down he's an intensely modest man who doesn't like to put his name on things. In any case, so now we're in the Biden administration, where you figure out how to mass produce, mass distribute, mass administer a vaccine into a community, a public health community that's really not geared toward mass vaccinating adults. And it's free and it's readily available. And he did everything he could to get good information out there, to decrease bad information, which is almost impossible, and try and use influencers. And then you just hit a wall. And so he did the only thing he could do at that point, which was to compel people to vaccinate by mandates. So, and I think that's it. I think that's the answer to the question. I don't, when we had our discussion, you'll appreciate this, Jayatri, at the Franklin Institute for the Bauer Science Award, we had all these sort of decision analysts, risk analyst people that were advising us on who to pick to be the Bauer Science Award winner this year. So here are people who are experts in decision making, experts in convincing people how to make decisions under uncertainty, experts in communicating risk. And I said to them, what do you do to that sort of 65 million people who don't want to get the vaccine? They all said the same thing: mandate it. So it's just stuck.
So the other piece of that, though, is I think we've reflected a lot on some of the historical mistrust of medicine in, particularly in communities that, have been mistreated in the past. What do you see in the current climate that maybe moves the needle on that trust?
I don't know. I mean, I don't know. I think you're right. I think there are historically communities that don't trust the medical system. They don't. They feel that they've been ignored or treated badly, and they just don't trust it. I mean, what you can try and do is you can try to get people with whom they identify, whether it's someone from a religious organization or or educational organization or sports or entertainment or whatever, you can try and do that. But, I just think it's really hard. Very,
Yeah.
very, certainly we see it in the Philadelphia community.
I mean, one of the things so we've been working with the Philadelphia Department of Public Health to support their efforts in getting out to under-vaccinated neighborhoods in Philadelphia and help them get information out to people, just because some of the barriers are that, there's this deep digital divide in Philadelphia, and, there are people who don't have access to, high quality information on the internet. There are many communities that just have limited English proficiency. And so we're working with them to, try and give them tools for simple, accurate information that are translated into 6 different languages. But ultimately, part of the key is to work with, I think, community partners who are there on the ground in their neighborhoods that they see every day, that, it's not necessarily the Department of Public Health who's going to be the one, to move the needle there. So I think, those kinds of efforts are going to be key in getting this last push. Whether we get to the conspiracy theorists is probably a bigger question.
I don't know if we're ever going to get past this.
Yeah.
I think that there's just a group that's so dug in. They don't want it. They don't want the vaccine. And I did either because I think a small part of that is because they really are scared. I mean, it is hard to imagine being injected with a biological that you don't understand. And you've seen things on the internet that shows that it's done harm. But I think the bigger issue is this whole notion of personal freedom, which does not apply here. I mean, it's if you choose not to get a tetanus vaccine, if you step on a rusty nail and you get tetanus, fine. Nobody's going to get tetanus from you. It's not a contagious disease, but this is a contagious illness. I mean, so you're making a decision for others. You just are. And it's just, what strikes me is that you'll have sort of these parents who are saying, no masking in the classroom, no mandatory vaccines, my body, my choice. Yet I think if you told them that there was a child in the classroom who, say, had a peanut allergy, they wouldn't insist on allowing their child to express their freedom, their civil liberty, by eating a peanut butter and jelly sandwich in that classroom. I think they wouldn't do that. I think they would recognize that child's vulnerability. Well, the only difference between that and this is that every child is vulnerable to this disease. So I don't understand that mindset. It's very it's just that they're dug in. There's no getting around it.
So as in our last few minutes here, let's look at what the future holds in terms of how we live with COVID moving forward, knowing that we may not ever be able to eradicate it. One question that came up was, do we see COVID being a seasonal virus that ebbs and flows during different times of the year?
Right. So historically, coronaviruses are winter viruses. This is at its heart a coronavirus. It's a bat coronavirus, but it has certainly mutated to now become a human pathogen. I do think we can get on top of this pandemic. I really do. I mean, it may be that the rest of the people who need to become protected become protected because they either die or they survive their infection. But I think we are getting there. I mean, you are starting to see a decrease in cases now. We've seen that before, so don't want to get too excited. But it's odd that it would be decreasing now as we're heading into the end of October. I mean, this is like winter respiratory virus season, and yet nonetheless, it seems to be decreasing. So I do think the sort of 80% of population that we've achieved is having some effect on this. And, we are still trying to vaccinate people. So I think we can get there. I do think that the virus will be endemic when it's all said and done. I mean, much like, flu and the four human coronaviruses that have been around, first identified since the 1960s, and they've been around since before that, they account for about 15 to 20% of the children who come into our hospital with winter respiratory infections. So I think it will just join that club. So I do think that the difference, however, between human coronaviruses or influenza virus or respiratory syncytial virus or human metapneumovirus or all the other winter respiratory viruses is this virus is far more heinous. It is. What this virus has the capacity to do that no other respiratory virus does, is it causes you to make an immune response to the lining of your blood vessels, your own endothelial cells. And that's why it can be associated with strokes and heart attacks. That's why children that come into our hospital with a so-called multisystem inflammatory disease have involvement not only of their lungs, but also liver, heart, kidneys. I mean, that's, unique in the world of respiratory viruses, and that the whole long hauler syndrome is really unique in that sense. This is a scary virus. That's the part of the virus that really scares me the most, is that the fact that it can cause you to have an immune response to your own blood vessels, i.e. cause vasculitis, because every organ in your body has a blood supply, therefore every organ can be affected. That's the heinous nature of this virus. That's what's so unusual about it.
And so I think that's a really important point to talk about, is how do we continue to study the long-term effects of COVID? Are there research projects that are following people who have these, and what are we looking for?
Yes, no, we're trying to figure out the pathogenesis. I mean, what it's the basis of this phenomenon, and I'm sure it's more than one thing. But I think you're starting to see papers now come out. It's interesting. Before the COVID pandemic hit, there were about 4,000 articles published a day in the medical and scientific literature. Now with COVID, there's 8,000. I mean, it's just an enormous amount of data that's being generated, enormous amount of money to generate data. So we're learning a lot. We're learning on the fly. I think regard to vaccines, we're learning on the fly. It's kind of like, building an airplane while it's in the air. It's been hard to watch. Although we've certainly gotten much better at taking care of patients who were sick. I mean, initially it was sort of all the emphasis was on ventilation, antivirals. I mean, now it's more on suppressing the immune system, and now we have certain immunological modifiers that we're now using, like these so-called JAK2 inhibitors, and so we've gotten better and better at that. But as is always true, you learn as you go, like it or not. You learn as you go. People will say, you know what? Yeah. Let me just wait till the learning curve's over, then I'll try that particular therapy. Learning curve's never over.
So, as we kind of look to history, a question is that, at one point we decided that the 1918 flu epidemic was over. What are the milestones that we're looking at by which we'll declare that this pandemic is over, whatever that may mean?
Yeah, no, I think that, and I don't know what that number is. We'll get to the point where there's a certain number of hospitalizations and deaths that we're more comfortable with. I mean, it's true of flu every year. Flu. The year before the pandemic, flu caused about 800,000 hospitalizations and about 60,000 deaths. And we live with that. I mean, do I think that if we masked and social distanced and we're much better about respiratory hygiene over the winter, that would make a difference for flu? Of course it would. I mean, typically 75 to 150 children die every year from influenza. Last year, one child died from influenza. I mean, if you want to basically eliminate respiratory viruses, just mask, social distance, close schools, close businesses, and restrict travel. That's all you have to do. Of course, it does shut down your economy. That's the downside, but.
Right. So there's these trade-offs that we need to think about. And those are not trade-offs that scientists can make on their own, right? So it's complicated. So the last question I want to pose to you, Paul, here is that as we look ahead, are there future pandemics that we need to be on the watch for? And are there particular environmental or social factors that can give us clues about where to look?
Well, the short answer is yes. I mean, you've had 3 pandemic potential viruses that have come up in the last 20 years. SARS-1 raised its head in 2002. It was pretty much defeated by 2004. MERS raised its head 10 years later, around 2012. It still sort of roils under the surface. The difference between those 2 viruses, and both coronaviruses that came from animals, and this virus, is that those 2 viruses, when they infected you, invariably cause moderate to severe disease. So you knew who was infected. This virus, most of the transmission is asymptomatic, and that's why you don't see where it's coming from, and so that's what made it so successful. Hopefully, we've learned from this. I mean, God knows what's got our attention. I mean, it really caused massive joblessness, massive homelessness, food insecurity. Increases in domestic violence, et cetera. We paid such a price for this virus, and what I hope will come out of this, at the very least, is an international surveillance system that the minute this pops up, we know what to do in terms of creating masks, creating ventilators, making sure we restrict travel, and testing, that you have to really be really good about testing and having really quick turnaround time of tests. We were terrible at testing. It takes sometimes a week or two to get your test back. How does this help? And so, I mean, we shouldn't have had to have depended on a whistleblower in Wuhan to tell us that there was a virus killing people. We shouldn't have. And so we have to have those international borders have to drop out while we see ourselves with what we are, which is a whole. We are a part of a whole. We're not individual countries, really, because and what happens in one country can affect everybody, as we've just learned the hard way.
Well, I think those are some important lessons to learn, and hopefully your vision of how to have that infrastructure in place to prevent the next one is something that will come to fruition. Paul, thank you again for joining us after such a long day. Thanks to everybody in the audience who tuned in to listen to our conversation. I'll put in a plug. If you enjoyed this conversation, we have some really fun conversations once a month on our digital platforms, Facebook Live and YouTube, where our science team talks about different science headlines that are in the news that have been catching our attention and talk about what it means for you. So we hope that you'll join us for that when it comes around next month. But in the meantime, thank you all for your ongoing support of the Franklin Institute. We couldn't do what we do without your support. And of course, Paul, you've been such an invaluable advisor throughout.
Yeah, I just want to apologize to Larry for any of the political references, but that's what you get with me. I'm sorry.
We always appreciate your honesty, Paul. Thank you. Have a great night, everybody. Thank you so much.
Bye-bye.